Next, we have a case discussion on cirrhosis. The moderators are Dr. Lakshmi Kumar and Dr. Sripada G. Mehendale. Dr. Lakshmi is head of the Department of Anaesthesia at Amrita Institute of Medical Sciences, Kochi, and Dr. Sripada is head of the Department of Anaesthesia at KS Hegde Medical Academy, Mangalore. The speakers for the session are Dr. Monica and Dr. Yashas, junior residents from KS Hegde Medical Academy, Mangalore.
At the outset, I'd like to thank the Department of Anaesthesiology at KMC Manipal for this opportunity, especially Dr. Swajit and team. Liver disease is becoming a very common problem, and we often encounter patients with liver disease coming for various procedures. So this is also an important situation for the students facing the exams because of the frequency.
So good morning. I thank my co-chair and the two young students who've come for this case. Postgraduates, could you raise your hands again, please? Postgraduates? If possible, if you could move to the closest space, then some of the questions which they don't answer or you have a different thought, we could probably discuss about this, okay? So we are now going to talk about a cirrhotic patient who's coming for a non-transplant surgery, right? Have the students been introduced? So I think you can do that.
Yeah, I can. We have two PG residents from KS Hegde Medical Academy, Mangalore, Dr. Yashas and Dr. Monica. They are final year residents of Kshema. I welcome them to the
So welcome Dr.
session.
Yashas and Monica. I'll just introduce the case to you. A 48-year-old lady is brought to the emergency room with a history of lower abdominal pain for 2 days. So she says she's been having a swelling at the lower end of the abdomen for some time. The swelling usually got worse towards the end of the day, but when she lay down on bed, she was able to push the swelling back inside. However, for the last 2 days, this swelling is not going inside when she is trying to push it. She also has pain over the swelling and has noticed a change in the color of the skin over the swelling. So the past history of the patient is relevant in that she gives a slight yellowish discoloration of the sclera, the eyes, for about 2 years. She also has a history of bilateral lower limb swelling and slight darkening of the color of the legs. Her facial skin has also become darker, and she reports on closer questioning that there's loss of axillary hair and a slight distension of the abdomen. An ultrasound that has been done over the course of the last year or so has reported a change in the echo texture of the liver. She is on treatment at this point on Udiliv 300 milligrams and lacilactone once a day. Her marital history, she's 48 years old, she's married with 2 children, and the last child was born 20 years ago by a lower segment cesarean section. So on examination, you find that she's conscious, oriented, afebrile, mildly icteric, and has bilateral pitting pedal edema. Heart rate is 88, BP is 110/70, respiratory rate is 28. Abdomen shows slight distension. She also has a small umbilical hernia, but there is a swelling in the lower abdomen corresponding to the site of the lower segment cesarean scar with slight reddening of the skin, no visible pulsations or peristalsis. So we now are looking at a lady, 48-year-old, probably with a history of chronic liver disease, coming with a incisional hernia which has become irreducible for management, right? So when we talk about cirrhosis, what is cirrhosis of the liver? Can you briefly describe the pathophysiology?
It is a pathological state where there is the destruction of the normal architecture of the liver because of deposition of fibrous tissues and regenerating nodules, leading to reduced mass and reduction in the function of the liver.
Right. So cirrhosis is actually a state, whatever the etiology may be. It could be, in our country, the most common cause is alcohol. right? You could have viral infections. 2 decades ago, that was a commonest cause. Essentially, the normal architecture of the liver is broken down, and you get the formation of fibrotic strands that will block the flow of blood away from the liver. So you have the formation of destroyed liver architecture with obstruction to flow manifesting as cirrhosis with portal hypertension. Now, what are the classifications that are available to grade a cirrhotic patient? Monica.
For the prognostic markers of cirrhosis, ma'am, there are two.
How would you classify? How do you know how badly cirrhotic a patient is when they come? There are grades, right? So how do you grade them?
Child-Pugh and MEL score, ma'am.
Right.
Modified Child-Pugh has 5 parameters: albumin, ascites, bilirubin, encephalopathy, and INR. And each one has 3 points, 1, 2, and 3. Whereas like in ascites, there is no ascites, 0.1, mild to moderate ascites, 0.2, and severe ascites, 0.3. And albumin, more than 3.5 will be 0.1, less 2.8 to 3.5 will be 0.2, and 0.3 will be less than 2.8. Whereas bilirubin, less than 2 is 0.1, 1.7 to 2 is 2 to 3 is 0.2, and more than 3 is 0.3. Encephalopathy, where there is no encephalopathy, is 0.1. Grade 1 and 2 of hepatic encephalopathy is 0.2, and grade 3 and 4 is 0.3. And INR less than 1.7 is 0.1, 1.7 to 2 is 0.2, and more than 2 is 0.3.
Right. So you basically have child A, which is 5 and
5 to
6
6
points is called child A.
Child A.
7, 8, 9 is
Child B.
And 10 and above is child C. So you also have another scoring system that's called model for end-stage liver disease. What are the advantages of MELD over the classical child A scoring?
MELD shows 90-day mortality, and it's for long-term outcome, whereas child is only for short-term. And
so the MELD was initially introduced to prognosticate the survival after using TIPS, right? But when you look at MELD, it has a logarithm that involves serum creatinine, right, which is a renal dysfunction is the most important comorbidity or adverse prognostic factor for cirrhosis. Also, subjective components of ascites and encephalopathy are eliminated, because you might think it's moderate ascites, I might think it's very significant. So that's subjective. Once again, encephalopathy. You may think she's lucid, but somebody else does not. So the advantage of MELD is it removes those factors and introduces the renal dysfunction, which by itself is the worst prognostic factor associated with chronic liver disease. Now, if you have a patient with cirrhosis like this lady, right, what are the changes in the hematopoietic system? Because when you have a patient, you go system-wise, right? So if you were to look at the hematopoietic system, what are the changes that you expect to find?
Patient can have anemia. It can be because of increased sequestration, and if patient
sequestration, destruction, right, in the spleen.
Yes.
Okay.
And then if patient has variceal bleeding,
variceal bleeding. Okay, it can get destroyed in the spleen. They can have ongoing GI losses. Then
thrombocytopenia.
No, we are talking about anemia. Ongoing losses, destruction in the spleen, then nutritional also. There is also associated bone marrow depression. Okay, then platelets being low. What about the counts? Do you think it would be normal, high or low in these patients? Like this patient is coming with an obstructed hernia and reddening. Do you think her counts are going to be high, or are they going to be normal or low?
High.
So they have a blunted response. They may not manifest elevated count. So it could be normal, sometimes it can be.
They're more prone for infections.
They are more prone for infection, correct. What about the platelets?
Platelets are thrombocytopenia.
Causes?
Increased destruction in the spleen because of splenomegaly.
Okay.
And thrombopoietin is also reduced.
Where is thrombopoietin normally synthesized?
Liver.
Liver. So liver does not synthesize thrombopoietin. Then?
Coagulation. Liver also secretes procoagulants and anticoagulants.
Normally synthesizes all the procoagulant factors except
3, 4 and 8.
3?
3, 4 and 8.
Really? Okay. I just thought it was a factor 5 and von Willebrand factor. Okay. So if you have a patient with liver disease, what is the commonest coagulopathic change that you would look at, and what are you worried about, and why is it that we are looking at that particular factor?
I would be worried about international INR.
INR, or the prothrombin time, right. And why is it that we look at the prothrombin time first? What factor is most relevant for the measurement of prothrombin time? Anybody PGs? 7. So factor 7 is the most significant factor involved in the measurement of prothrombin time, and it has the shortest half-life, earliest to get affected when you have patients with liver disease. Okay. What about changes that you have in the cardiovascular system? Is it normal?
A patient with chronic liver disease generally have hyperdynamic circulation.
Very good. Okay.
Because,
so how does that manifest?
It manifests as increased high cardiac output, decreased systemic vascular resistance,
Then?
and both diastolic as well as systolic dysfunction will be there. And
okay, what is that called? When you get
Cirrhotic-
systolic, it's called
cirrhotic cardiomyopathy.
cirrhotic cardiomyopathy. Okay, then
And patient will be having increased resistance to beta adrenergic response.
say that again. What are you trying to say?
Beta
Maybe she
adrenergic
should answer. Monica, go on.
beta adrenergic resistance
So
to the
what are you
beta
trying
adrenergic.
to say?
The
What does that
sympathetic
mean?
it won't be no response. Sympathetic response will be decreased.
So that's called a chronotropic incompetence, because there is a delayed conduction of action potential across the myocytes. If you give your standard doses of norepinephrine, they may have a blunted response. Okay, anything else?
Prolonged QTC, autonomic dysfunction might be there, and
I'm not sure
chronotropic
autonomic
effect.
dysfunction, but long QT again, all features of abnormal conduction. All that you said, systolic dysfunction, diastolic dysfunction, and in those centers that have a strong cardiology unit, if you look at them, they now measure something called the global longitudinal strain. Right? So if you want to know how well your patient's cardiac responses are, it should be more than this minus 18. Right? You have values that are less than that, it could probably indicate there is some amount of cardiomyopathy or cardiac dysfunction, and that's a new thing that I am seeing in cardiac reporting. These patients could likely have that. What about coronary artery disease in a patient with liver disease? Is it less? So if I tell you this patient's cholesterol is 699 total cholesterol, her triglycerides are 60, HDL is 40. So do you particularly think that she will not have coronary artery disease? What does literature say?
She will be more prone for coronary artery
Yeah,
disease.
that's a good guess, but no. She is not particularly more prone. Incidence of coronary artery disease could be just the same. And any idea, I think I spoke about it yesterday, any new scoring systems that have been introduced to evaluate this patient? I spoke about this yesterday.
The Mayo Clinic.
No. Anybody? If you had a cirrhotics, let's say coming for a transplant, not for a non-cardiac surgery, and you want to do a cardiac evaluation, ECG, echo, and next step. What's the next step? So if a patient has metabolically associated liver disease or is diabetic, then they recommend that you can consider doing a calcium scoring, and scores above 400, you do angio. Otherwise, based upon the risk factors, you may want to do your stress test. Stress tests again can be fallacious in this group because of the chronotropic incompetence that you mentioned. If you make them walk a treadmill, the heart rate is not going to increase. So you actually have to measure adequacy of stress testing by percentage of target heart rate. Targeted heart rate during exercise is 220 minus age in years. So these patients may or may not mount that heart rate response. Even if they mount that heart rate response, BP at that time drops. So if you look at the other variable called the rate pressure product, it falls to below 15,000, your test is not truly a test. You know, it doesn't fit the norms to classify that a patient does not have factors. So this is just for your knowledge. I think I don't have to go that deep in this subject. Okay. Now, Yashas, what about changes that one might find in the kidney? I think all of us ask about questions on what is hepatorenal. So, we don't really expect a well compensated cirrhotic like this lady to be in hepatorenal syndrome. But what are the changes one would expect in the kidney in a patient who may have liver disease?
Because of the vasodilators, there is hyperdynamic circulation and reduced SVR. This leads to splanchnic vasodilation.
There is splanchnic vasodilatation. So what happens to the kidney?
Reduced perfusion to the kidneys.
Correct.
This leads to again activation of the renin-angiotensin aldosterone system.
Right, and can lead to a renal vasoconstriction, which can manifest as elevated creatinine. There are original classifications have been changed. Right, it used to be HRS 1 and 2, now it has become HRS AKI, HRS non-AKI, HRS CKD, and so it's a little bit more complicated, but I think if you understand. Now, how do you know that the renal damage is because of the liver disease and not intrinsic to the kidney? Is there anything? I know it's like I'm asking out of the blue.
Urine osmolality.
Urine osmolality. Anything else? I just mentioned
Urine
yesterday,
sodium.
when do you call a patient having kidney disease? They have to have a few
GFR
things
is
like, no, not
reduced.
just GFR, you need to find the presence of proteinuria or the presence of hyaline cast or urine sodium more than, I forgot, I think 20 or 10, I am not sure, right? And those things will tell you, if it is that, then it is due to the kidney. If it is not, and the urine sodium is less than 10 and the urine is clear and the patient does not respond to a volume challenge which may include albumin, you have ruled out sepsis or nephrotoxic drugs, then it is only then you make a diagnosis of AKI related to liver disease. So, let us come back to our patient before everybody gets bored. So, this is all about the patient, and I am going to tell you what we did as part of her investigations. Her hemoglobin was 8.5. Total count was 6,400, platelets were 75, creatinine was 0.75, sodium was 135, potassium was 4.1. Her ultrasound of the abdomen showed a controlled ascites, but the liver had coarse echo texture. Albumin was 3.5, bilirubin 1.8, INR 1.4, right. She is 48-year-old, no other relevant history other than chronic liver disease, has come up with these investigations were done in the casualty. You are now asked to see the patient, and the surgeon of course wants to proceed for an emergency hernia repair. Will you ask for any other investigations, and if so, which? And what is your tentative plan of anesthesia given these investigations? You will have to tell me which child or MELD grading she is in. She is 48 and she weighs 65 kgs. Her height is 160 centimeters.
Serum bilirubin being 1.8, it is 0.1 of child puke, and albumin 3.5 is 0.2 of child puke.
No, it's
2.8 to 3.5 child puke. 2.
It's more than, well, I'll put it as 3.6. Okay, fine, okay. Whatever you want. Okay, if you want to give that 2, you can give that 2. I might have given 1. Okay.
And INR 1.4 is child puke 1.
So, what child grading does she come under?
And ascites is controlled, so it will be child puke 0.1. So, it will be 4 points with no hepatic encephalopathy. So, that is also 1. Child puke A.
A. Okay, supposing you did put her albumin as 2, then how many points would you have? 5 plus 1, 6, that's also child A. So, I will make it a little, okay fine, we will keep it at this. If you read your child puke classification, it is not the absolute INR, it is a number of seconds from control, right. How many seconds from control do you see here?
12 seconds from the control.
That is how much?
0.2.
So, there is more than 4 seconds, there is usually, I do not know which classification, mine may be older than yours. So, I think I calculated to give you a score of 7. So, let us say for whatever inaccuracies I have in putting this up, she is in
Child
a
tube
low
B.
child B, right? Appears to be compensated. She's not totally decompensated, or if she has, it's being controlled. Her ascites is controlled. She has an irreducible umbilical hernia. Now, how would you proceed? You've told me about the child grading for this patient. Now, I'm putting this question to you. Do I have only 6 minutes left? Okay. So, if this patient only had did not have any evidence of bowel. You know how they evaluate a hernia, right? An ultrasound is always done. Yes. It did not show any bowel, right? It only showed mesentery, and the vascularity, there didn't seem to be any evidence of a compromised vascularity. Child B, what is your choice for an open hernia surgery?
I'd first.
Both of you can say, you can consult and say.
My plan would be a subarachnoid block.
Your surgeons are really good.
If they are really fast.
Right. Any other thoughts from the audience? Any of the seniors have different thoughts? Can we give a regional to a what appears to be a controlled child B presenting for a hernia which does not involve bowel? Yes, no, maybe? Right. So, my side of the story, I might go ahead with a central neuraxial blockade. I am not sure if my surgeon will finish it in 1.5. I might put an epidural, or I might just go with a spinal. But here the decision tilts when you have bowel inside the hernia, or there is evidence of compromised vascularity of the bowel, in which case it becomes a obstructed hernia, and a risk for anything with opening means bowel resection and anastomosis, and in those situations there is a chance of liver functions worsening. Now, if you told me even for this child B with an uncomplicated hernia you wanted to give GA in the exam, it is absolutely right. So, it may be experience, operator dependent judgment. As a rule, we say in child B, be careful. But because of my experience or my comfort, I might choose that. But if you say any child B, I will only give general anesthesia, that is also right. You just remember that if the bowel was not involved, it's a very straightforward case of hernia. You can give your standard GA and get away with it. How would you manage a case of obstructed bowel in a hernia in a patient with cirrhosis, who is probably child B?
My plan would be general anesthesia with rapid sequence induction.
Why do you need to give rapid sequence induction in this case?
Since it's obstructed, the more chance.
Since it is bowel obstructed. Okay. How would you do a rapid sequence induction?
Initially, I would pre-oxygenate after shifting the patient.
Will you put a Ryle's tube pre-induction?
Since this patient can have esophageal varices, it would.
Okay. Right. Child B, oh right. One of the things I didn't mention in the echo was the portal vein, portal hypertension or size of the spleen. That could tell you. I agree that you have varices, but if you felt, okay, if you don't want to put a Ryle's tube, how can you protect yourself from aspiration in the current era in a patient who has a bowel obstruction?
Modified.
Ultrasound?
Gastric
So, the
ulcer.
ultrasound will tell you how bad the situation is, and if you are going to see a very large dilated stomach out there, it is okay to gently pass a Ryle's tube. Ryle's tube is less traumatic when swallowed by the patient than by your manual insertions, right? Yes. If you see a dilated stomach, if you see a cross-sectional area more than 10, I think you can aspirate, and then I know in the exam you are supposed to say you will aspirate and remove the Ryle's tube, because leaving a Ryle's tube in can make the esophageal sphincter patulous and predisposed to reflux during induction. Okay. Choice of drugs?
For induction, I would use graded doses of propofol.
Okay.
And my opioid of choice would be, if available, remifentanil or fentanyl.
Has it come to your state? So, for us it's pending. It's come to one of the hospitals in Cochin but hasn't reached us. Okay. So, we don't know how to use it. So, don't say something you don't know. Say what you use, because what your consultant uses will be scientific and correct.
Fentanyl would be.
Fentanyl, how much?
Since this patient is 65 kg, I would give 100 to 120.
Okay, fine. 2 mics per kg fentanyl. Then, would you give Midas or
I would avoid benzodiazepines.
why?
Since its metabolism is, and it can worsen hepatic encephalopathy.
I don't quite agree with that. Okay, fine. So you want to be cautious on your dose of benzodiazepines. Okay. Then, intubation with relaxant?
Relaxant, since I'm giving rapid sequence induction, I would use succinylcholine initially and then maintain with atracurium or cisatracurium.
What are the doses of cisatracurium for intubation?
For intubation, it's 0.2 mg per kg.
Okay, 0.15 to 2 mg. Choice of inhalational anesthesia?
Ideally, I would use desflurane or sevoflurane.
Okay, you have desks available at your center?
Yes.
Right. And what are the goals of anesthesia when you're doing anesthesia for a CLD?
My goals would be to maintain hemodynamic stability, because any drop in any hypertension would.
How do you manage hypotension?
I would prefer giving vasoconstrictors than fluids.
What is your vasoconstrictor of choice?
Phenylephrine or ephedrine.
Norepi? I thought norepinephrine should come as a first choice. Frenin you can give as initial boluses. Analgesic options? The surgeon has opened the same incisional hernia, that same site through which this thing, and says I might extend it slightly, I am going to repair the umbilical hernia along with it. As he opens, we also drain about 500 to 700 ml of ascitic fluid. We did say there was controlled ascites, right?
Yes, ma'am.
Any of you? Monica? Choices on fluid management?
If you are draining ascites like large volumes of
What is 500 to 700? You have to tell me if it's large, medium or small.
parasitasis.
Goldilocks. Is it large volume? Is it small volume? Is it no volume?
It's a large volume,
500, 700?
a small volume. So
Dip, dip, dip.
liters, I taught this later.
So how
500
much,
to
what
700
would you do if there was, sorry.
We don't load with fluids, rather we give colloids, albumin we can give, or
How much of albumin will you give?
1.
So ऊपर के आना है. 7 to 8 grams of albumin per liter of ascites is the replacement that
Per
is
liter,
recommended.
7 to 8.
IV fluid of choice?
Plasmolyte is the IV fluid of
Why?
choice, because ringer lactate can be avoided, because liver is the organ where lactate is converted to bicarb and lactic acidosis might be there.
Right, right. What is the sodium content in plasmolyte versus sodium content in ringer lactate?
137 in
In what?
plasmolyte.
Should know that.
Yes.
You hang that up every day, right? Choices of analgesia?
Multimodal analgesics.
What is multimodal?
I'd like to give, avoid NSAIDs, and I'd like to give PCT maximum 3
What
gram
is
per day. Paracetamol,
Okay.
3 gram per
I've
day.
heard it
or,
as PCM. Now I hear PCT. Okay.
Or local infiltration
How
can
much?
be given. Maximum 3 grams per day can be given, paracetamol.
Is it safe for liver?
Up to 3 grams per day it is safe for liver.
But you're saying you won't give ringer lactate because the lactate is not metabolized. So how are you justifying paracetamol? Justify. How is paracetamol metabolized?
COX-2 metabolization.
Okay. So it is okay to give paracetamol. You can give opioids, you can give local infiltration, you can give
Patient control
abdominal
analgesia.
plane blocks, you can give erector spiny block. All of this can be given safely. We give it to liver recipients, so this lady is quite okay. Meanwhile, what you need to watch is worsening of the liver functions after surgery and correction of coagulopathy only if there is witnessed bleeding. Okay? So paracetamol can be given because paracetamol is normally metabolized in the liver and it is only the breakdown product, the NAPQI, which can accumulate and that can be metabolized by glutathione. And what is the drug that you give as a precursor of glutathione? N-acetylcysteine. So, if you are really scared about paracetamol toxicity, you just need to give that N-acetylcysteine. I haven't seen any overdose of paracetamol with my practice. Okay, I think it's time and I'm going to end. Any other questions, any contradictions to whatever I have said? I'm very happy to take questions. Clarifications? Nobody has any doubts? Okay. So, shall we finish, Doctor? Yeah, I think I have to thank my co-chair and the two students, Yashish and Monica, who very bravely took up this challenge and did a great job. It wasn't rehearsed, it was only the basic skeletal questions that were provided. So their answers are extempore. Well done to both of you.
Thank you.
Thank you, speakers and moderators. I would request the moderators to kindly be on the stage. I request Dr. Malavika, our HOD at KMC Manipal, to kindly felicitate our speakers. We have the quiz finalists. So the winners for the quiz finals are Team Legend, Wait for It, Dari, Dr. Nikhil and Dr. Sushmita from KMC Manipal. Team Narcotic Nerds, Dr. Indumati and Dr. Arpita from Yenapoya Medical College. Team Needle Ninjas, Dr. Sheetal, Dr. Debahuti from KMC Manipal. Team PSG, Dr. Sri Shravan and Dr. Kavya from PSG Institute of Medical Sciences. Team Ketofol, Dr. Junejo and Dr. Raki Jose, Goa Medical College. Congratulations, winners.
Anaesthesiology and pain medicine at Sri Ramachandra Medical College. Her areas of interest are obstetric anesthesia, airway and pediatric anesthesia. Without further ado, let's welcome Dr. AKILANDESHWARI.
Good morning to one and all. At the outset, I would like to thank the entire organizing committee of APGAP, Dr. Anita Shenoy ma'am, Dr. Shweta and all the faculty who have worked for this and inviting me and for their hospitality. Thank you one and all. Pulmonary hypertension and anesthesia. So, the World Symposium on Pulmonary Hypertension in the year 2018, they have redefined pulmonary hypertension as whenever there is a mean pulmonary arterial pressure which is more than 20 millimeters of mercury at rest, or a mean pulmonary artery pressure of more than 30 millimeters of mercury during exercise, along with the increase in pulmonary vascular resistance which is measured as more than 2 Wood units. This is the criteria for defining a patient to have pulmonary hypertension. Having defined this, so is it a measure which can be easily measured? Is this quantum easily measurable by clinical methods? It is not possible. And when you look at the clinical symptoms which the patient has due to pulmonary hypertension, it is often non-specific in nature because the cause of the pulmonary hypertension could be multifactorial and the symptoms might be most often relating to it, and they are not specific for pulmonary hypertension. Next, when you look at the treatment part of it, it is often an etiology based treatment, and there are knowledge gaps with regard to the regular use of pulmonary vasodilators and phosphodinodilators in pulmonary hypertension in all of these patients. So, when in this scenario, when there is a patient who is coming for non-cardiac surgery, we are faced with perioperative anesthetic challenges in terms of assessment, in terms of the severity of the pulmonary hypertension, and what are the cardiac adaptations which we have that have taken place in the patient, which could interfere with the anesthetic management. So, it could be because of the drugs which we are using to induce anesthesia, the sympathetic blockade, and the alteration in the cardiovascular physiology that occurs due to the use of induction agents, inhalational agents, and the muscle relaxants, the stress response, the fluids, and the positive pressure ventilation. All these are going to ultimately affect the way in which the pulmonary hypertensive patients are going to behave in the intraoperative period. So, when you look at the clinical classification of pulmonary hypertension, it is divided into 5 groups. Type 1 patients are patients who have primary pulmonary arterial hypertension, and most often this group includes patients with idiopathic pulmonary hypertension, Eisenmenger syndrome, and pulmonary hypertension secondary to connective tissue disorders. And group 2 includes patients with left heart disease, which could be valvular heart disease, or a patient with systolic diastolic dysfunction, and patients with cardiomyopathy. And group 3 patients are patients who have developed pulmonary hypertension secondary to their lung pathology. And group 4 are patients who have pulmonary thromboembolism related pulmonary hypertension. And we have group 5, which is of unclear etiology. Primary pulmonary hypertension of the newborn has been recently included in the type 1 group. With this clinical classification, they have further redefined the pulmonary hypertension based on the hemodynamic parameters, based on what is causing this hypertension. Having said about the types of pulmonary hypertension, when you look at hemodynamic classification, the first one is precapillary pulmonary hypertension, where the hypertension is at the level of the pulmonary arterioles, that is prior to the capillaries. And so when you measure the pulmonary wedge capillary pressure, it is less than 15 millimeters of mercury, and your vascular resistance is going to be more than 2 Wood units. This precapillary pulmonary hypertension is found in patients who are under group 1, 3 and 4 and 5, which we have seen before, except for left heart disease, which has isolated post-capillary pulmonary hypertension. The other groups belong to precapillary pulmonary hypertension. But as the disease progresses, the patients can have both precapillary and post-capillary pulmonary hypertension, which cannot be differentiated clinically, and you need right heart catheterization to identify whether it is both pre or post-capillary hypertension, because the only differentiating point is here, in spite of the resistance and your pulmonary artery pressures being more, the wedge pressures are also higher in combined precapillary and postcapillary pulmonary hypertension. So when we look at the incidence of pulmonary hypertension, as told, it is often majority of the patients fall into the category of group 2, which is associated with left heart disease, followed by unknown thing, and next will be the secondary to lung disorders. Idiopathic pulmonary hypertension is quite few in number, which is only 3% of people who have primary pulmonary arterial hypertension, which is group 1. So when we look at the timeline at which this clinical symptoms and the change in functional capacity and all the features of right heart failure develops, as the disease progresses, what happens is the changes in the right heart are the first one to manifest, and these can be picked up only by using a periodic echocardiography. So whenever the patient has symptoms relating to pulmonary hypertension such as exertional dyspnea, syncope, it means that it has progressed to a larger extent and we are not in the initial phases of pulmonary hypertension. So evaluation by echocardiography in all the patients whom we mentioned before, regular periodic checkup with echocardiography will help you in identifying patients at an early level, because it has been found that earlier the definition of pulmonary hypertension was between when it was more than 25 millimeters of mercury. But what they have found out is patients with in the hypertension in the range of 20 to 25 also have disease severity similar to the other groups. So that is why the cutoff has been brought down in the recent definition. And let us look into the pathophysiology of pulmonary circulation. Before that, the physiology of pulmonary circulation is very important to understand. We know that there are two pulmonary trunks which divide and they perfuse the lungs, and they divide periodically around 15 to 16 times before they become the pulmonary arterioles, then they become the capillaries, and then they form the venules. So there is a difference in the pattern of muscles and the elastic fibers which are there in this. The proximal pulmonary trunk has more of elastic fibers in the medial layer, whereas your pulmonary arterioles prior to capillaries, they have muscle layers. When compared to other arterial structures, the amount of muscle in the pulmonary arteriole is relatively less. And so this makes it more compliant in the distal part of the circulation, whereas in the proximal part of the circulation they have only elastic lamina which helps to push the blood forward into the capillaries. So it is a low resistance circuit and they are capable of recruiting more vessels for whenever there is an increase in blood volume due to exercise or due to other factors. And the third thing is the regulator of endovascular tone is majority of the time it is made by the endothelial cells which secrete prostacyclin, endothelin and all the nitric oxide. These are the mediators which regulate the arteriolar tone. So what happens with onset of pulmonary hypertension is, the first one is the normal vessel where the endothelial layer is thin and it has endothelial cells which secrete all the intermediate substances which I told you. Whereas with the onset of pulmonary hypertension, there is an imbalance in the vasoconstrictors and vasodilators which are produced by the endothelium. There is neointimal proliferation, smooth muscle proliferation also occurs, and ultimately it becomes into a plexiform like lesion. The end result of all these is there is an impedance to right ventricular ejection. This is the primary pathological change that occurs secondary to pulmonary hypertension with the onset. Once the pulmonary hypertension sets in, what are the adaptive changes that occur in the right heart ultimately decides the severity of the symptoms which the patient is going to develop. Initially, for the increase in RV after load, there is increase in myocardial contractility, and this is achieved by right ventricular hypertrophy which occurs secondary to increase in PVR. As the pulmonary vascular resistance progresses, the right ventricular hypertrophy is unable to adapt to this increased resistance, and ultimately there is right ventricular dilatation. Whenever there is right ventricular dilatation, we know that there is a phenomenon called interventricular dependence which causes the septum to move into the left ventricle. So the compliance of your left ventricle is also limited, and hence your left ventricular outflow ejection also gets reduced, which ultimately results in a vicious cycle of cardiogenic shock ultimately. So what started off as a hypertrophy ultimately results in dilatation, and ultimately it will become a cardiogenic shock in spite of your LV being normal. These are the changes, these are the peculiar changes with regard to right ventricular failure. And what are the other factors? In addition to the morphological changes, there is increased ischemic demand to the right ventricle, because as it is, right ventricle has a lesser muscle under physiological condition, the muscle mass is less. But the perfusion of the vessels happens both during systole and during the diastole. With right ventricular hypertrophy, it becomes like a left ventricle where the perfusion is dependent only on the diastolic filling time. So in spite of its increased need myocardial consumption, it is deprived of myocardial oxygen supply because the luxury dependent circulation becomes converted into a diastole dependent circulation once the right ventricular hypertrophy sets in. Then secondary to right ventricular dilatation, what happens is there is right atrial dilatation which pushes them into which causes arrhythmias, which further decreases the filling of the ventricles and then ultimately results in right ventricular failure. So it is an end result of morphological, ischemic and biochemical changes that ultimately result in RV failure. So these changes, when such patients go into a non-cardiac surgery or cardiac surgery, they have major adverse cardiac events in the form of right ventricular failures, arrhythmias and cardiogenic shock with respiratory failure, and this increases depending upon the type of surgery which the patient undergoes and also on the duration of surgery. So how do we preoperatively assess these patients? In the early stages, they have dyspnea and fatigability which could be non-specific in nature, and as it progresses, what happens is because of decreased left ventricular perfusion, the onset of chest pain, syncope and palpitations, and there is a change in the functional capacity of the patient which occurs. These it is a severe form of pulmonary hypertension. In addition to forward failure, there is also venous congestion which results in early onset of renal failure and liver congestion. So the incidence of multi-organ dysfunction is quite common in patients with pulmonary hypertension. So the clinical signs can be loud P2, pansystolic murmur due to tricuspid regurgitation because of your right ventricular dilatation, and raised JVP and hepatojugular reflex. These are the signs the patient presents with during the last phase of the disease. So evaluation of all systems is very essential, and when you look at the ECG, you look for features of right ventricular strain, right ventricular bundle branch block, and the most important thing is echocardiography. Echocardiography, you assess the right atrial size when it is more than 26 square centimeters, and when your RV-LV ratio is equal, which is not normally found in a regular LV-RV ratio, or when your RV is more than your LV, which you find in the extreme right hand side, it means that it is a severe form of pulmonary hypertension and the risk of RV failure is more. The next thing to assess is your tricuspid annular plane systolic excursion. When it is more than 1.5, it is normal, and when it is less than 1, it indicates severe dysfunction. Echo plays a major role in patients being in the perioperative period for preoperative assessment, intraoperative for identification of pulmonary hypertensive crisis or right ventricular function, and in the postoperative period in these patients. So risk stratification, we have the 4-strata risk stratification where the functional status and the 6-minute walk test are taken into consideration. So whenever a patient is unable to walk at least 150 meters, or when they fall into the category 4, it indicates a very high risk. And in addition to that, you include your BNP values and your NTP pro-BNP values. When they are more than 1200, then it indicates a high risk. What we have to understand is, in spite of having a low risk, the type of surgery and the emergency nature of the surgery increases the risk further in these patients. So when these patients are presenting to your pre-op assessment clinic, it is very essential to identify these high-risk groups and categorize them so that we can optimize preoperatively and operate them in a place where we have advanced cardiac critical care centers, including the provision of ECMO, which is very essential because that is ultimately going to be life-saving in these patients. So optimization, the first thing is treating the primary etiology. Then you decrease your pulmonary vascular resistance by giving calcium channel blockers, which is indicated only in group 1 pulmonary hypertension, and selective pulmonary vasodilators such as your prostacyclin analogs or your bosentan, which is your endothelin receptor antagonist, can be given when it is in the severe form. And oxygen therapy, and what are the reversible factors which help in decreasing the PVR, such as if it is a respiratory patient, optimizing your bronchodilator therapy, controlling respiratory infection, and controlling cardiac failure takes a priority before institution of phosphodiesterase 5 inhibitors or your pulmonary vasodilators. We have to remember, in a patient with pure left heart disease, if you are going to give pulmonary vasodilators, it is going to increase your preload to the left heart and it can further aggravate cardiac failure. So it is very important to categorize and give pulmonary vasodilators only in indicated cases for severe RV dysfunction in the intraoperative period. Perioperative goals include maintenance of RV function and avoid triggering pulmonary hypertensive crisis in the intraoperative period, and your OR preparation should include defibrillators, because amiodarone or beta blockers can further depress myocardial contractility, and whenever there is atrial arrhythmias, it is better to electrically convert them rather than using pharmacological interventions to correct the rhythm abnormalities. Hypothermia is a potent trigger of hypoxic vasoconstriction, so ensure normothermia by instituting fluid warmers and hot convective blankets. And you have a combination of infusions which are kept ready, vasopressors to counter the hypotension, because even a minor degree of hypotension can compromise the RV perfusion, ultimately resulting in RV dysfunction. So noradrenaline infusion and vasopressin infusion can also be loaded, but make sure the infusion rate is less than 0.03 units per minute, because if the rate is increased, the dosage is increased, it will ultimately result in coronary ischemia. Then you have your inodilator infusions, and then Inotropes such as dobutamine are also a part of these. Epoprostenol IV has been successfully used in case of acute pulmonary hypertensive crisis. So, in addition to this, your mandatory monitors include pre-induction invasive arterial blood pressure, central venous line obviously to give all these agents, arterial blood gas analysis, and serial monitoring of lactates and your venous oxygen saturation of at least more than 70% ensures that your cardiac output is very good. Though we won't be able to get, I don't think all of us are well trained in getting a transesophageal echocardiography. Serial monitoring of your venous oxygen saturation will help you to identify patient's cardiac output status is good or not, and if the perfusion is good, to maintain the lactate levels in near normal. In addition, cardiac output monitoring using a pulmonary arterial catheter and transesophageal echocardiography is mandatory for invasive procedures and something like organ transplant or major thoracic or abdominal surgeries. When it is being done, it is mandatory. The role of neuraxial anesthesia, when you look into it, we have spinal and epidural blockade which can be given, but restrict your spinal only when it is a lower limb procedure or whenever you don't need dermatomal level of blockade more than your lower lumbar levels, because even a minor degree of hypotension is detrimental in these patients, and you are justified in giving graded epidural in patients with Eisenmenger syndromes where there are successful case reports of graded epidural anesthesia, not only for analgesia, even for operative delivery it is being recommended. So, next, looking at GA, which is more challenging because the effects of anesthetics, all the anesthetics are going to affect the preload, afterload and the contractility of the heart in varying levels even in a normal person. In these patients, these effects are going to be further increased, and the effect of positive pressure ventilation on venous return is going to decrease your right ventricular preload. At the same time, it also increases your PVR because of the compression. The positive pressure ventilation with higher tidal volumes and increased plateau pressure can increase your further PVR. So, a decreased venous return with an increased PVR will ultimately result in suboptimal right ventricular outflow. And the other factors, that is hypoxia, hypercarbia, acidosis and temperature management and the surgery related effects also compound to this. So, how do we conduct safe GA? Pre-oxygenation is mandatory in these patients, and since they do not tolerate even a minor degree of hypoxemia, it is very essential to para-oxygenate these patients using high flow oxygen flows or Thrive if it is available. A liberal dose of opioids can be given so that your induction dose of intravenous agents is negated, is minimal, and then you wait for the responses, titrate to response rather than giving weight-based doses in these patients. And then intubation should be quick and successful using, and first attempt intubation should be done in all these patients using the video laryngoscopes or other measures to decrease the intubation response by using a remifentanil bolus or a additional dose of fentanyl. All these will ultimately result in increasing your PVR. When we look at ventilation strategies, it should be a lower tidal volume ventilation so that you, and at the same time you should avoid atelectasis also, because whenever there is atelectasis, when you look at the graph, you see the extra alveolar vessels get compressed and further it will increase your PVR, and when there is over distension of your alveoli, that time also your PVR increases, and you maintain your PaCO2 levels at the level of 30 to 35 millimeters of mercury. Make sure that when you look, analyze the ventilator waveform so that there is no auto peep which sets in, and your plateau pressures had to be monitored so that gives you an early warning that the patient is going in for pulmonary edema. So, how do we maintain RV function? By as we said, norepinephrine infusion can be started at a low prophylactic dose so that you avoid fall in systolic blood pressure, which is, and the ideal target is to have your systolic blood pressure more than 90 millimeters of mercury or at least 20 millimeters above your pulmonary artery pressure so that both the RV and the LV gets perfused. right atrial pressure should be kept to the minimum so that whatever level the perfusion happens, the mean arterial pressure is maintained. That is the optimal filling pressure for that ventricle. And if you have cardiac index monitor, it should be more than 2.2 liters per minute. So choice of vasopressor, norepinephrine is the preferred vasopressor, and vasopressin, as I told you, it should not exceed more than 0.03 units per minute, and dobutamine, milrinone for improving your pulmonary hypertension and as well as to improve your myocardial contractility. Use combination of vasopressors so that whenever there is hypotension, it should be thought of as pulmonary hypertensive crisis. So the take home point is you combine your vasopressor along with your pulmonary vasodilator or your ionodilators. So it is very essential that you do not stop the ionodilators. Instead, you can counteract the hypotension by using a vasopressor such as noradrenaline so that your RV function is not compromised, and in very resistant cases, switch off to earlier ECMO. Fluid management, CVP is not a reliable indicator. So ensure that there is no large rapid volume boluses which is being given, and titrate to loss which is guided by clinical parameters and your monitoring lactate levels, and the trends in the CVP monitors will be a better guide rather than a single value, and transfusion trigger should be kept at a higher level because anemia is poorly tolerated. And the post-operatively, all these patients need to be kept in the critical care unit, and pulmonary rehabilitation is very essential because that will again trigger increase in PVR. Pain management is essential, and early use of CVVH because renal failure is more common in these patients because of venous congestion. So the approach to the patient is, why is there a pulmonary hypertension? What is the cause? What is the severity? How is the right heart? Is there a failure? The need to optimize, and your intraoperative goals should center around prevention of RV dysfunction. So this should be the approach. To conclude, echocardiography plays a vital role in all the phases of patients with pulmonary hypertension. Pre-op assessment using your BNP levels along with clinical assessment is mandatory, and regular use of pulmonary vasodilators is not indicated in all groups of pulmonary hypertension, and invasive hemodynamic monitoring is mandatory when you are anesthetizing patients with pulmonary hypertension. So thank you.
The session is now open to the audience for any queries.
That was a superb lecture, Akila. Just a thought that I wanted to put in. So when we talk about pulmonary hypertension, I feel it should not be an echo diagnosis. The echo merely states what the right ventricular systolic pressure is. Right? So you know that if you have values more than 45, it's likely. So an absolute diagnosis of pulmonary hypertension is only made when you measure the pulmonary, that is, it's a combination of measurement of pulmonary vascular resistance and demonstrating absence of a raised LAP. Like we see it in a lot of our liver patients, the RVSP will be 45 plus RA. Then you give them albumin and Lasix, it comes down. So I think the pulmonary hypertension liver population is only 2%, but nearly 10% will come with such elevated pressures. I just thought that should be mentioned when you're talking.
Yes,
otherwise so beautifully covered.
Yeah, as you said, thanks ma'am for adding on to the liver part of it also.
Thank you, ma'am, for the clear guidance on managing such challenging cases. Moving on. Now we have a Procon session on epidural versus truncal blocks for thoraco-abdominal surgeries. I am delighted to welcome Dr. Anand Somayaji and Dr. Sandeep for the next session as moderators. Dr. Sandeep Shankar, an associate professor in the Department of Anaesthesia at Yenapoya Medical College, Mangalore, with a focus on regional blocks. Dr. Anand is an assistant professor in the Department of Anaesthesiology, Father Muller Medical College, Mangalore. We are fortunate to have their expertise with us and moderate this wonderful session. Let's also welcome our speakers for this session, Dr. Surya, Junior Resident from Father Muller Medical College, Mangalore, and Dr. Arpita, Junior Resident from Yenapoya Medical College, Mangalore. I now hand over the floor to the moderators.
Good morning, one and all. First and foremost, thank for the APGAP team for giving this opportunity, and also I am telling congratulate this topic is very important because a lot of people have a confusion so many times in the theaters, which one we have to go at, whether epidural or the truncal blocks. Definitely nowadays more and more ultrasound came into the picture. A lot of people are preferring to truncal blocks, but still lot of people have a confusion whether which one is the best. Instead of going much more and more, we have two panelists. One is Dr. Surya, final year PG from Father Miller Medical College, and Dr. Arpita, final year PG from Enapaya Medical College. Both will go with the pros and cons sessions, and following which both will debate, and we will also let you know.
Good morning, everyone. Thank you for inviting us over here. We thought we'll make this session a little interesting session. Okay, what we are planning is
all of these advantages are not seen in your truncal blocks. These are just. There have been many meta-analysis comparing, in this case, epidural and transverse abdominal plane block. It is shown that the post-operative analgesia, post-operative pain scores in your in epidural block is far less compared to your truncal blocks in immediate post-operatively, as well as 12 hours and 48 hours post the surgeries. One more major advantage that we have is its beneficial effects on the cardiovascular system. That is your improved myocardial blood flow, improved oxygen balance, improved tissue oxygenation, as well as epidural has shown to have some anti-anginal effects as well. Here we have a British Journal of Anaesthesia article where they've shown the anti-ischemic effects of thoracic epidurals in your cardiac and non-cardiac surgeries, where they've also stated that it improved diastolic function in patients with coronary artery disease. Moving on to your cons of truncal blocks. Firstly, there can be bowel perforations, hematoma, liver and spleen lacerations, as well as intrahepatic injections of local anesthetics, retroperitoneal hematomas, intravascular injections, and it has a higher risk for systemic toxicity when compared to your epidurals. Also, one major disadvantage of your truncal blocks is the requirement of an advanced skill set, where the anesthesiologist requires an in-depth knowledge of sono anatomy when delivering the block, since it's not very accurate without ultrasound. And with respect to transversus abdominis plane block, it requires multiple injections if bilateral analgesia is required in the surgery. Any catheter placements in the truncal blocks are easily dislodged when you compare them to epidural blockade. Also, it has an increased risk of pneumothorax and infections compared to your epidural blocks. Thank you.
so I think you can defend yourself with us telling that the epidural is better than your truncal blocks. So going back to his slides, what do you think you can answer about the cons of it?
Go to the slides of the Surya.
Regarding bowel perforation, so now in our institution at least we have been trained very well by our expertise to how to scan and perform the technique. So it is very unlikely that we cause a bowel perforation. And hematomas, it can be if a patient is having coagulopathy, it's possible in epidural too. And coming to laceration, again, we are having ultrasound and we are doing under supervision with a better good training, so it is very unlikely, it's very rare. And last, it can be with epidural too. Last, if it's intravascular insertion of catheter, it is not that this much difference. And requiring advanced skill, I agree with that, but we are being trained now with truncal blocks, with using ultrasound that too, and so it is not that advanced. It depends on which type of block you're giving also.
Surya, what are you telling now? She's telling all these things can be possible even in these things. What is your opinion?
So as I said, higher skill set, she admitted to it, requiring it. So if a person is not well versed with sono anatomy, it will be difficult. Also, the vascular structures are more closer in most of your truncal blocks with compared to epidural.
But epidural vein is also very much closer to you. Good morning, everyone. I'll be talking about pro for truncal blocks, which is a new frontier in regional anesthesia. Before starting, I would like to discuss a case scenario. This was a 28-year-old male patient who was posted for expiratory laparotomy under general anesthesia. Pre-operatively, he was very restless and hemodynamically unstable, so we directly proceeded to general anesthesia. Intraoperatively, due to bowel edema, closure of abdomen was not possible. But in this situation, giving since the incision is very large, giving epidural and positioning the patient is very tricky. So we went ahead with the ultrasound-guided bilateral quadratus lumborum block, and it was actually compared that the analgesia post-operatively was good enough. Later in 2021, Raval N, he questioned if epidural analgesia is improving outcome or it is adding risk. He told that epidural analgesia can cause harm and hinder the early mobilization, which is a main factor of ERAS protocol. There are other less invasive techniques like peripheral blocks like paravertebral block, tab block, rectus sheath block, and also QL and ESPB block. Coming to cons of epidural, as we know, accidental dural puncture is very common and it can lead to PDPH, back pain, which is also around 35%, epidural vein cannulation by catheter, which can result to last, faulty placement of catheter, patchy and insufficient block, total spinal anesthesia, and epidural abscess and hematoma, and spinal nerve root injury. I do agree there are limitations with truncal blocks, technique-wise, and also it can produce incomplete analgesia and inconsistent analgesia. But there are various studies being done, and also in recent one where Daniel Vary in 2024, he described the realities of facial plane blocks. He told that the superiority of epidural blocks was less evident when compared to the truncal blocks and tab block. He also told that there is a main advantage of facial plane block, that is, it can be performed in supine position when we have limited access to patient back at the end of the surgery. And also, facial plane block can be performed in patients where epidurals are contraindicated, like coagulopathy. And also, one of the example is recently they described an external oblique intercostal block, which was given to a after liver transplant patient, and it showed a satisfactory result. He described 5 key points. That is, first, the trend is increasing. The trend of usage of facial plane block is increasing, but the evidence of continues to evolve. There is limitations, and also when compared to thoracic epidural, the opioid use is higher in facial plane block, but the other patient-centered outcomes are similar. And indications like where epidurals are contraindicated, we always have truncal blocks, and choosing facial plane block should be always patient-centered. This again describes the advantage of comparing paravertebral blocks with the epidural, and they also specified that you can also go ahead with the tab block for midline and explorator laparotomies. With increasing emphasis on multimodal analgesia and shift to minimally invasive surgeries, thoracic epidurals have lost popularity and facial plane blocks are in trend now. The unique feature is that no nerves or plexus need to be identified. You can just inject the drug in the muscle plane. And also with the increase in use of real-time ultrasound, the truncal blocks are more accurately performed and has improved success rates. There are various types of truncal blocks like abdominal wall blocks, chest wall blocks. Coming to TAP, it is mainly for anterolateral aspect, analgesia to anterolateral aspect. There are different approaches, subpostal, lateral, posterior. This is images showing the insertion. A rectus sheath block mainly gives analgesia to your periumbilical area in the midline laparotomy cases. Coming to QL block, it is nothing but the posterior extension of TAP block. But studies have shown that the local anesthetic, they do reach paravertebral spaces. So they do cover visceral pain too. Coming to chest wall block, we have PEC1, PEC2, SAP blocks, and paravertebral blocks. And now the studies have shown that one meta-analysis concluded that paravertebral block was as effective as thoracic epidurals. And the same study, they also concluded that ESPB block was compared to paravertebral block, which is easier to perform, simple and a safe technique to perform, and gives same analgesic effect. ESPB block is again a facial plane block, which has communication with the paravertebral and epidural spaces, so and also communicates with intercostal spaces. It can also be used as a continuous ESP block using a perineural catheter. Coming to summary, thoracic epidurals are invasive, high cost, labor intensive, and are associated with high rate of failed epidural catheter placement. In addition, the vasomotor and motor paralysis induced by the neuraxial anesthesia, it lowers the blood pressure and prolongs the immobility of patient and prolonged paralytic ileus. This hampers the achievement of two key roles of ERAS objectives, that is early oral feeding, refeeding and mobilization. So hence the advantages of TEA are increasingly being diluted with the evolution of less invasive surgical techniques and the growing efficacy of ERAS protocol. Finally, the new regional anesthesia technique have emerged with which provide good hemodynamic stability.
Dr. Surya, you want to debate on anything regarding what she told? She told me so many things. You know, you can debate and we'll give it open to the, so many seniors are there in the, also there. So we'll come to the conclusion. But what is your opinion? See, it is not that you are not against the truncal blocks. You are also favoring, I'm not telling, but still you can debate on that.
She said epidural is labor intensive. I would say the same for any truncal block. And as for failed epidural catheter placement, there have been studies showing that it's equal, there can be a patchy block when you're comparing truncal block with epidural as well. And again, multiple injections required.
Okay, so I think what we need to know is type of surgeries that we need to choose, what procedure that we are going ahead, because I think if it's a standard elective procedures and a major thoraco-abdominal surgeries, I would always go for epidural first, because for the major fact that something called neuroendocrine stress response, which is mainly inhibited by the thoracic epidural more than your truncal blocks, so that the intraoperative period is very free and very stress-free basically with the thoracic epidural. When you have a major cases which is posted on an emergency basis and you have an anticoagulant in picture, yes, epidural is out of the picture and your truncal blocks favors in. Also, when you have a case where they would have posted for a laparoscopic surgeries and then they would have converted it into an open in between the surgery, and then you can't do an epidural placement probably post-operatively. So there you go ahead with the truncal blocks. We both being regional anesthesia specialists, I think what we can say further is with the advancement being into the ultrasound picture, obviously truncal blocks plays a huge role, because mainly blocking all these things will always help the patient in the post-operative pain management. But I think with an epidural placement, the patient will be more comfortable in breathing, more comfortable in the post-operative rehabilitation phase, and with the catheter being in situ in a thoracic epidural, the patient can have a longer analgesia also, whereas if you have to keep a catheter here, the chances of dislodgement here is more than that of epidural is what I feel. So with all those being said, I think we can ask anybody else if...
My opinion, the thing is in epidural, for major cases, the advantage is intraoperative, the hemodynamic balance is really good and post-operative analgesia. But if you come to the truncal blocks, the intraoperative, the hemodynamic is not as good as what I feel like epidural, because of the neuroendocrine response, how it manages. But post-operative pain relief, definitely if you're thinking, I always prefer the truncal blocks more than the epidural. But I'm giving over to the seniors, those who are there here, also can have some suggestion, like Lakshmi Madam, Matthew Sir and Anita Shanai Madam, all these people can put forward some words on this, because all of us has to know this. So we want some suggestion from you also, ma'am.
I think you just mentioned the type of surgery. So I think that's very, very crucial, because the meta-analysis on epidurals prolonging the length of hospital stay and duration of catheterization was partly in lap and partly in open. So you don't want to put an epidural in lap surgery today, that's for sure. So the alternatives end up being either intrathecal morphine or truncal blocks. So that's where I feel there is a role for these truncal blocks. I don't know, I would agree with Sandeep in saying post-operative pain relief with a truncal block given on the day of surgery is better than an epidural. I would actually challenge that statement. But for me, truncal blocks will be given for lap surgery, and I would only go for epidural if it is open. And if there is coagulopathy, the bilateral ESP catheters seem to be working well for me for robotic donors. And for renal recipients, a unilateral catheter works well most of the times. I think when it doesn't do well, it could be my technical inability, but about 85-90% they don't need opioids post-op, which means the thing is acting. So these are my thoughts. I would ask Dr. Anita and seniors.
It will also depend on the patient's condition, because it would be better to do an epidural if the area is vast, for example a polytrauma, and then also the anesthetist confidence in doing. Some people are good at epidural, some people are good at truncal. So there are various factors: surgery, patient's condition, and also will depend on the last one I said.
Yeah, I agree. The patient condition is very important. Depends on how easy or difficult an epidural is going to be in that particular patient. And for lap surgeries, you would probably not want to put an epidural, but only if they convert, then you have to give some kind of pain relief, and you can always go with the facial plain blue. Whereas it's open right from the beginning, I usually prefer an epidural. Yeah, personal.
Good morning, everybody. A nice presentation. Both of you spoke very well. As a proponent of one or the other technique, I know you have to give strong points and some negative, which not necessarily really negative. So that is the job of yours. But for the audience, I would think you have to really pick and choose what points are really worth it to take it for that particular technique. For example, I'm not pointing out any particular thing, but just to say, when you say 31% back pain is there, epidural, all that, if you link this, no surgeon will, most of the time they demotivate the patient, and if you say something, so back pain is because of this, finished. You are calling it last nail in the death, this one, of the coffin of the epidural, or for that matter, spinal also. I understand pro-con, you try to highlight the things which is for your technique and against the other technique. But as other seniors have already mentioned, it is depending on and also the moderators are also mentioned, it depends on how extensive is the surgery and whether it is a bilateral block is required. For example, any central midline incision require bilateral block also. And it is well known that from anterior midline going towards the posterior, anything which is on the midline, that will give less of pain relief in an intra-abdominal procedure compared to when you go as backwards towards the spine. For example, if we give only in rectus sheath block, that is much less comfortable for a patient who has undergone abdominal surgery compared to tab block, which is compared to QL block, compared to ESP block, compared to epidural. I would say like that. As you go more medial, some of the visceral fibers will also be attacked by your local anesthetic, and that makes their pain relief much more comfortable. Definitely when you don't need bilateral, when you don't need this kind of extensions are not there, it is always better to have a local the truncal blocks, and you have to design it, and depending on the expertise, yes, but at the same time, I think as postgraduates, most of you are young people, you know these techniques are available, ultrasound is available, all of you should be familiar with this, and that factor you should bring it down. I am ready to give epidural, or I am ready to give ultrasound block also. So you should learn that, and then you have to take a decision weighing the pros and cons. That's my opinion. Thank you.
Thought I would just add one small point. An epidural actually will allow you a little bit more flexibility because you can give opioids also through an epidural compared to anesthetic to a truncal block is what I would say.
I guess we do follow that of late many are following the local, skipping the local anesthesia part in the epidural and going more pro for opioid consumption. Thereby, your point about being the last is also, negative to it. So, thereby saying that I think epidural is by far the standard and the gold standard for the thoraco-abdominal surgeries. But in case and situation deems that you can't give thoracic epidural or at the start of the surgery, then I think the truncal blocks will favor the patient and will actually have to be given for such surgeries at least, so that the patient can have a better post-operative period. Otherwise, we got to go with an patient control analgesia for these patients with the fentanyl or anything. So, that being said, that both are equally good, but both have to be based on the situation that deems fit for that. So,
sorry, I would like to add one more point. For extensive surgeries, I think when you're considering bilateral blocks, you should also take into note the dose and the concentrations of the local anesthetics being used, because it can cross the toxic dose as well if you're considering for long duration. If it's extensive surgeries, if it's smaller incisions, then I think blocks are still good enough.
Any opinion from anyone? Seniors?
Shall I make a comment? Sure, depends on the patient and condition, of course. Definitely, epidural is not at all out. It's still in the run. So, but being a regional anesthesiologist, I'm more towards truncal blocks. Like many situations, as Madam rightly said, most of the surgeries, abdominal surgery, actually epidural is gold standard in abdominal surgeries, actually, post-operative analgesia, everything. But most of the surgeries, except cesarean section, most of the surgery they do under laparoscopy. So, we can have a managed laparoscopic pain relief in an excellent way with all the combination of truncal blocks on rectus sheath with the rectus spinae block. But if it is converted to an open one, still epidural is the best thing for at least for the immediate postoperative period. But we have a different other scenarios also, like a patient having last week we had two patients. One patient was an 85-year-old lady and another one is a 40-year-old male with 4 to 5 posterior rib fractures. So all the times we used to put an epidural, and now we can have a rectus spinae block, even bilateral. If it is one side, is better. But the problem with the posterior rib fracture is that patient can't lie down. There's a very big distressing situation. If you couldn't put a rectus spinae catheter, patient is very comfortable. The pain score is always after that 48 to 72 hours. It is less than 2 to 3 only. So that is very comfortable. You can manage that thing. And still the Arpita point of view, and epidural is still labor analgesia. Nothing can replace epidural. Still epidural holds the best option for the labor analgesia. So depending upon the patient and conditions. And my take regarding the joint replacement, I will discuss on my presentation. Thank you.
Thank you, sir.
We thank our moderators for this session, Dr. Anand Somyaji and Dr. Sandeep for the speakers, Dr. Surya and Dr. Arpita. I request Dr. AKILANDESHWARI to join Dr. Anand and Dr. Sandeep onto the stage. I request Dr. Shushma TK, Associate Professor at KMC Manipal, to facilitate the speakers.
Moving on to our next session. It gives me great pleasure to welcome Dr. H.M. KRISHNA, our esteemed former HOD, who now serves as Professor and Head of Department. He now serves as Professor and Head of Department of Anaesthesia at AIIMS Mangalagiri. A man of few words, but when he does speak, his words carry the weight of profound insight and experience. His dedication and contributions to the department have been invaluable, and we are delighted to have him back with us for this conference. Let's extend a warm welcome to our very own Dr. H.M. KRISHNA for his video session on functional analysis of Mapelson circuit. Over to you, sir.
Good afternoon, everybody. Well, thank you very much. My affiliation might have changed to All India Institute of Medical Sciences, Mangalagiri. But my gratitude to this Department of Anaesthesiology at Kasturba Medical College, Manipal, whether it is for the alumni, whether it's for my colleagues, the faculty staff, my postgraduate friends, the technicians, the nurses, everybody, if I have missed anybody, will always remain and will always keep increasing. Times will change and we need to keep moving. I'm sure after 6 years, 8 years, 10 years, when I come here, I wouldn't hear all this cheer. I would be as stranger here as anybody else would be. But live in the present moment. This is special, and thank you very much for making this special for me. It was supposed to be a video session, but I apologize. It could be a misnomer. I couldn't capture the video of the gases flowing in the circuit and then show you the alveolar gas, the dead space gas, the fresh gas. What best I could do was put some very simple, primitive animations just to increase our understanding about the concept. Is it still relevant to discuss about Mapelson system? The Mapelson breathing circuits are almost as old as I am. So if I am relevant, probably they also would be relevant. That's what I feel. But many institutions, many places, we often don't see these systems being used. We have all switched over to the circle systems for evident advantages, obvious reasons. But remember, they still have their place in some of the places where you find the circle system are bulky, not available, resource depleted, or even when circle system is there, you always rely on these as your trusted backup. How many of you use Mapelson circuits at least once in a while? Please raise your hands. My God. Okay, it's a very relevant lecture. I had a fear that nobody would raise hands or very few would. Whether you use or you don't use, they are still there in the exams. Be it theory, the practical, table viva, whatever it is, you'll have all bulk of circuits lying there on the table, right from starting to identify what the circuit is, and that itself could be confusing, to how they function, advantages, disadvantages. So these stock questions would be there. So breathing systems are nothing but a mechanism which facilitates, enables the transfer of the gases, medical gases like anesthetic gases, from a source like your anesthesia machine or any other source of these gases to the patient in both the directions. But that doesn't mean any rubber hose, rubber pipe would act as a breathing system or a breathing circuit. They also should help facilitate the removal of carbon dioxide. They should make sure that air doesn't sneak into these, and they should make sure that the temperature of the breathing gases are conditioned, maintained. It also maintains the humidity in the mixture of the gases that are breathed. And to make sure that they don't disconnect, they don't kink, they don't take undue course, there are a lot of components of breathing systems, and you might be asked to identify some of these, or even asked to mention the differences between these, or the characteristics of these, or the ASTM regulations of these components of the breathing system. We had a very good debate between the epidural and the truncal blocks. We are now living in the phase where what excites the anesthesiologists, what excites the students is anything related to ultrasound, be it the regional blocks, be it the pokers, be it the whatever it is. Anything related to ultrasound, it is the trending thing. So it was a couple of decades before for the breathing circuits. people would sit, classify the circuits in all possible ways, and people would discuss on that, bring in the modification of circuits and say, prove one is superior to another, have lot of research on that. So all these things will have their own time and they'll keep moving ahead with times. Artificial intelligence is knocking doors. Of course, it's all confusing, classifying the breathing systems into different ways based on different criteria, and if an examiner really wants to harass you, well, this would be a very nice way of asking and then do things. But to keep it simple, the classification simplest will be a carbon dioxide absorber is present or a carbon dioxide absorber is absent, whether unidirectional, bidirectional flow. And in this system of classification, the Mapelson circuits come under the carbon dioxide absorber is absent and there is bidirectional flow of gases in the circuit. So these Mapelson breathing systems are flow controlled carbon dioxide washout circuits, which means there is no absorber absorbing the carbon dioxide. From the circuit, the carbon dioxide gets washed out, and that is predominantly determined by the flow of the fresh gases that you set, in some cases even the breathing characteristics of the patient. And there are 5 basic types, alphabets A to E, and F was added later. William Wellesley Mapelson, who lived to a very productive, active life of 92 years, was not an anesthesiologist, was not a medical doctor, he was a physicist. But he was closely associated with the Cardiff University and the hospital and worked in collaboration with the anesthesiologists there, doing a lot of research and developing, improving these circuits. And he was a very humble person. He said that all credit to me is because I knew these 5 alphabets and I gave these 5 alphabets to these simple things. Those diagrams are very important for your exam because the moment the examiner sees that in your answer manuscript, we know that, okay, this person knows about this circuit and is not bluffing whatever further he is writing. So when we go into the functional analysis of these circuits, the Mapelson A system is popularly also called as the McGill circuit, and we know that it is best for spontaneous respiration. When you are identifying this circuit, the hallmark of this would be that it's the only circuit with the fresh gas inlet which is away from the patient end. Fresh gas inlet is away from the patient end, A for away. So when we are doing the functional analysis, when you are writing your answers in your answer paper about the functional analysis, for this lecture I would be using the color green for the fresh gas. You could use dot, you could use stars, arrow, whatever that you want in your exams. I would use the blue color for the dead space gas, and I would use the red color for the alveolar gas for the subsequent description. Let's look at the expiration. The patient is breathing out into the Mapelson A McGill's circuit. So what comes out of the patient first when he breathes out? Is it the alveolar gas or the dead space gas? So it's the dead space gas. So we had said that it is depicted in blue color. But from the machine end, what is coming? The fresh gas flow is flowing into the circuit there. What do we do with the APL valve during spontaneous respiration? Do we keep it open or closed, or what do we do it? We leave it open because patient is breathing spontaneously. We don't want any extra resistance to be there. We want some of the gases to be vented out, so that we leave that open. Now, till a pressure builds up in this circuit, remember, your disc or whatever valve is there in the APL valve is not pushed up, and the gases cannot flow out of the APL valve. So the dead space gas has come out from this side, and from that side the fresh gas flow is coming in. Following the dead space gas, you have the alveolar gas which is following right up. So now slowly the breathing circuit is getting filled up with these gases, which means a pressure is developing within the circuit. And once sufficient pressure is developed within this circuit, what happens? The APL valve, the disc or whatever is there, it just is pushed up because of the pressure, and what exits is predominantly the alveolar gas. So by virtue of the design of this circuit, what are we achieving? In the expiration, what is going out of the circuit is predominantly the alveolar gas. We still have a mechanism to conserve the dead space gas, which would be warm and humid, and you're also cutting down on the amount of the fresh gas flow that you would be using for every breath. So in inspiration, so theoretically your alveolar gas, most of it has been vented out of the circuit by the APL valve. What the patient breathes is the dead space gas and the fresh gas. So I hope things are clear so far with regards to the spontaneous respiration. So if you have understood, got this, the concept becomes very clear. For any circuit, you draw the circuit, you know what is coming out of the patient, you know where the APL valve is located, and you know whether its circuit is good for spontaneous or controlled, and then accordingly, if it's a good one, you show more of alveolar gas going out. If it's a bad circuit for that type of respiration, you show more of fresh gas and the dead space gas going out. So that's the trick when you write your answers in the exam. So for controlled expiration, we'll go by the same thing. Patient is breathing out. Now what happens to the APL valve in controlled ventilation? Is it fully open? You can't squeeze the bag if it is fully open. So we keep it partly open, partly closed. Okay. So what comes out is first the dead space gas, and from the other side the fresh gas flow is coming. What follows is the alveolar gas, but this much pressure is not enough to open the APL valve. Why? The APL valve is partly closed now. So the APL valve, when the patient is under controlled ventilation, will open up only when the bag has distended, and then you squeeze the bag to give the next breath. That's when the inspiration happens, because this is a controlled ventilation. But by this time, what happens is there's a lot of alveolar gas there. You have not given enough time for the alveolar gas to escape out of the APL valve. So when you squeeze the bag, there's a tendency that some amount of alveolar gas also is pushed into the lungs. So there is rebreathing. There's not enough washout of carbon dioxide. And by the time you complete the inspiration, it's not only the alveolar gas that is going out. You would see that even the fresh gas, the dead space gas is important. It has the whatever fresh gases that you want, and it has not participated in gas exchange, and it is humid and it is warm, but we are losing on that. So your Mapelson A or McGill system is probably not that good for your controlled ventilation. So advantages of Mapelson A system: best for spontaneous respiration, because we just saw in the functional analysis why it is. So economy of the gases is there, humidity, temperature is better maintained, and minimal resistance during spontaneous respiration. Disadvantage: not good for controlled ventilation for the reasons that we saw there. Plus your APL valve is quite distant, it's near the patient end. So every time you have to adjust the valve, you have to go there, and there could be a drag on the circuit which could result in accidental extubations. It's not suitable for children less than 30 kgs. A LAC circuit is a modification of the Mapelson A circuit. So let's move on to the next one, Mapelson B system. So it looks like this. Okay. And once again, very simple. So where is the fresh gas flow coming? It's just behind the APL valve. So that's the key point here. The fresh gas flow is just behind and very near to the APL valve. So when the patient is breathing out, the dead space gas comes out first. The fresh gas flow is also coming. It is going in the back direction, trying to fill up the bag. It's also coming out. But remember, since it is located just behind the APL valve, when expiration happens and when the APL valve, this valve opens up, you have the alveolar gas going out and you have also the fresh gas flow which is leaking out. So there is a loss of fresh gas flow because the fresh gas flow inlet is located just behind the APL valve there. So in inspiration, what happens? You could have the rebreathing of some of the alveolar gas in this, and you could have the mixture of the fresh gas and the dead space gas also going in. When it comes to the controlled ventilation, key things that you have to remember is APL valve is partly closed. It doesn't open up as early as in your spontaneous respiration. So what happens is for a longer period of time, the circuit keeps getting filled up. So you have the alveolar gas also entering the circuit. So when you squeeze the bag, it's both the alveolar gas and the fresh gas flow which goes out. So in Mapelson B and C, there is much more loss of fresh gas flow from the circuit because the inlet of fresh gas flow is sitting right there behind the APL valve. But the advantages are it's less bulky, less weight, very light. Okay, you don't have a very long circuit that is required. But the disadvantages we describe, the location of the fresh gas, and because of that, you can also have the rebreathing. Mapelson C system, I don't know how many of you use, at least in KMC Manipal, it's very popular, very useful for shifting the patient from one location to another because you see it's such a small thing and you have a control over the APL valve. Everything is located in a very comprehensive way there. But in exams, you get confused between B and C. So both are sitting there. Which one is B, which one is C? In the tension, you would tend to forget. Very often there are institutions now which have phased out Mapelson B and C from the exam table viva if you are lucky, but in some places it is still kept. B has this corrugated tubing. In Kannada, bala means tail. Okay, so bala is tail. So there is a bala in Mapelson B circuit. Okay, so there is a tail of that corrugated tubing, whereas you wouldn't have that in the Mapelson C circuit. The functional analysis of Mapelson C system is exactly same as that of Mapelson B. Why? Because the only additional element in Mapelson B is that bala or the tail of the corrugated tubing. Otherwise, the disadvantage of the fresh gas flow inlet located just behind the APL valve is there in Mapelson C also. But the superior advantage of C is its compactness. D system is still used widely everywhere, and this is how it looks. It's actually a T-piece. If you look at this patient end, you will see that it is a T-piece with an additional attachment to that. And Bain and Sporel brought a modification to this Mapelson D system where they brought the coaxial system where, remember, the fresh gas flow is still going near the patient end, but only thing that the tubing of the fresh gas flow, they have put it inside the corrugated tubing, so making it a coaxial system. So that's the difference between the actual Mapelson D system and the Bain circuit. So one is a coaxial system which gives it an additional advantage of maintaining the humidity and the temperature. The other one is the Mapelson D, where the inner tubing comes from outside. That's all. So in both the places, remember, the fresh gas flow is near the patient end. So by now you should be very familiar with the analysis of the expiration and inspiration. What comes out of the patient in the initial part? Dead space gas. So you put those colors there. But here, remember, in the inner tubing of the Bain circuit, gas flow is continuously flowing. Because it is flowing continuously, what is breathed out of the patient cannot enter the inner tubing which is carrying the fresh gas flow. So the alveolar gas, the breathed out gas, will enter the outer tubing and it will go and fill the reservoir bag. So by the time the valve opens up, your alveolar gas has reached the APL valve, and even when the patient is breathing spontaneously, predominantly it's the alveolar gas which is vented out of the APL valve. So if you know whether this circuit is good for spontaneous, controlled, or both, you can manipulate your diagram showing the alveolar gas going out or the fresh gas going out, dead space gas going out. Okay, that's the trick of remembering it a little easily. So inspiration, when the patient breathes, you are not squeezing the bag. Remember, it's a spontaneous respiration. So predominantly, it is the fresh gas that is going, and by economy of the fresh gas flow, you can also make sure that the dead space gas is breathed by the patient. So the factors decreasing breathing are high inspiratory-expiratory ratio, slow rise in inspiratory flow rate, slow flow rate during the last part of exhalation, and long expiratory pause. In controlled ventilation, APL valve is partly closed. The fresh gas flow is coming from the inner tubing, the green color tube that you see within the vein circuit, and then it moves through the outer tubing, and then it's a good circuit even for controlled ventilation. So the alveolar gas is also vented out. Some amount of dead space gas and fresh gas flow also gets vented out when you squeeze the bag. How much of fresh gas flow goes out, how much of dead space gas goes, it depends on how you control the respiration. Whether you are prolonging the inspiratory time, whether you are increasing the respiratory rate, whether you are adding an inspiratory plateau, these factors would increase the rebreathing. So this itself could be a short note, the advantages of vein circuit. So you have a good warm humidified gases because of the coaxial system. Lightweight, you can carry it anywhere, CT scan, here, there. So all peripheral locations it would be useful. Good for both spontaneous controlled ventilation, adult and children it could be used. So it's called as a universal circuit. Scavenging is easy, low dead space, low resistance. So if your inner tubing is damaged, then the whole thing adds up to the dead space. That's one of the disadvantage. And less than 20 kgs, usually it's not recommended. AIIMS TPs, Mapelson E circuit, popular for the pediatric. It's just a T shape. You could have some specifications of the dimensions. So what happens during expiration? You have the dead space gas that's coming out, the alveolar gas that's coming out, the fresh gas flow is coming from one of the limbs, and you know the direction of the movement of these gases, and there is venting out of the expired gases during the expiratory pause. So when there is an expiratory pause, that's when the fresh gas flow comes and it pushes out all the expired gas out into the atmosphere. And when the patient breathes in the fresh gas and maybe some amount of dead space gas. If one of these limbs of the T is small, that's why very often we put some reservoir there also. If that is not there, you could have sucking in of the air during respiration that can cause the air dilution. By occluding this upper limb intermittently, you can have controlled ventilation also, but be careful. If you are not careful, you can cause barotrauma. Good pediatric circuit for these reasons that are mentioned, but you could cause barotrauma if you are using your finger to control the respiration. You should not be doing that. And the feel of the reservoir bag and the buffering effect of reservoir bag is not there with this. Jackson-Rees modification of AIIMS TPs, Mapelson F system. So you have a corrugated tubing and the reservoir bag there. There is no APL valve. If you put some valve there, it becomes another modification. The functional analysis is very similar to that of AIIMS TPs when it comes to the JR circuit. Remember, it's not mandatory that just because it's a pediatric case, you have to use a Jackson-Rees circuits or AIIMS TPs. It's your comfort. There are pediatric circuits which are available for the circle system also, which can safely be used in pediatric practice as well. They have their own advantages, but some of us, we always like to have the feel of the bag of the Jackson-Rees circuit, to give those tiny, small tidal volumes to the neonate and see the bag movement in a better way than in a circle system. It's all personal preferences. So these are the advantages of the Jackson-Rees circuit: low dead space, low resistance, lightweight, suitable for both controlled and spontaneous ventilation. Even if you increase the length of the corrugated tubing, it doesn't add to the dead space or the work of the breathing. So this point is an advantage for both Jackson-Rees circuit and the Bain circuit. You can make the circuit as long as you want without increasing the resistance to the breathing. Of course, you still need a high fresh gas flow. Even if it's a small, tiny baby, you would need something like 4 liters per minute of fresh gas flow and all those things. All these things would happen only if you use the recommended flow rate. And these are the recommended flow rates. These were recommended even before your era of your end tidal carbon dioxide. Now we have the advantage, luxury of that. You can see those values and actually titrate the flows, but they correlate very well with this. And what is advised for controlled ventilation for Mapelson D is recommended for spontaneous for Mapelson A, and what is advised for spontaneous for Mapelson A is advised for controlled for Mapelson D. So that way it is easier to remember. And even if you are totally blanked out in the exam, the best bet, best number to take is around 2 to 3 times the minute ventilation. That wouldn't be wrong. So these are still in clinical practice, clinical relevance. Your show of hands proved that. And when we understand the functional analysis, we are more mature to use them in our clinical practice and can get more marks in the exam. Thank you very much.